Respected colleagues, today I would like to share some information about the indication of intracytoplasmic sperm injection called ICSI. And this is a very controversial issue now in ART practice. And in the past, ICSI has been considered an add-on. With the new evidence we have recently, is it still an add-on in our current practice? As we know that in our ART practice, the success rate is never 100%, and many of our doctors, they have repeated failure, and there is a pressure on the patients and their doctors as well to do some extra thing to improve our treatment result. And we are living in the era of evidence-based medicine, so we lack of evidence to support the efficacy of the new treatment and maybe the approved treatment, but in unselected patient populations. And we call those kind of treatments add-ons. We have to verify the different kind of evidence related to new treatment. Maybe we do not have evidence, or we don't have enough evidence to prove that the treatment is effective or not, or we already have some evidence that prove the treatment have no effect. And many of our new treatment is potentially effective until we can prove it effective or not. And based on the recent editorial in RBM Online, ICSI is not mentioned as an add-on in IVF treatment now. We have here that assisted hatching, BGS, MC, PIXI, intrauterine culture, reproductive immunology tests and treatment. With those kind of treatment, we have no evidence that is effective or safe. And with this group of treatment, artificial egg activation, elective freezer cycle, amnio glue, endometrial stretching, BGS, time-lapse imaging, we have some conflicting evidence on the effect. And there's no mention as on have strong evidence to prove. When we come to intracytoplasmic sperm injection, the introduction of ICSI was in 1992, almost 20 years ago. And at the beginning, it is introduced to treat severe male factor infertility. And after that, we expanded into treatment for azoospermia, men who sperm can be collected from the testes. And after that, ICSI has been expanded for patients with couples with mild or borderline semen analysis, or even with normal sperm count. And the trend has been increased very rapidly during the past 10 years. Also, many non-male indications for ICSI have been introduced. The most controversial indication for ICSI is for non-male factor infertility. We have many retrospective and even RCT to verify the effectiveness of ICSI for non-male factor infertility compared with conventional IVF. Data show that we can have similar or lower fertilization rate per oocyte retrieval, similar ovoid placocyst formation, lower implantation rate, similar or lower live birth rate, similar or lower cumulative live birth rate. But most of the data were from retrospective studies. We have only large RCT published in 2001. This is the only strong evidence we have on the effect of ICSI for non-male factor infertility. When we look at the first RCT, it is published in 2001. Data were collected from 4 IVF centers in the UK. This is some of the main results of the study. Even the failed fertilization rate seemed to be higher in the IVF group, not significant. The author found that they have a higher fertilization rate for oocyte retrieved with IVF compared with ICSI. And they also found that in the IVF group, they have higher implantation rate and even live birth pregnancy. So the conclusion is quite affirmed that the IVF group have higher implantation rate and pregnancy rate per cycle, and we spend more time with the ICSI. So the conclusion is that ICSI offer no advantage over IVF in terms of clinical outcome for non-male factor infertility. And as a matter of fact, it's even worse in this study. So this is very strong evidence from an RCT, good design. What happened after we have that kind of good evidence for ICSI use in non-male factor infertility? The indication for ICSI has been increasing even after the time the publication, the article came out, 2001. You see that the incidence of the percentage of ICSI in ART practice has been increasing sharply during the past 20 years. And actually the group of non-male factor infertility has the highest increase in ICSI use. So that means that even we have good evidence that ICSI does not work in non-male factor infertility, the indication for ICSI in ART practice kept increasing rapidly. Another data from the US show that the overuse of ICSI in many centers in the US recently. When you look at the small center all over the country, you see that the ICSI rate is more or less 70% of the started ART cycle. Even the male factor indication is only 1/3. When you look at the indication for ICSI in big centers in big cities, the uses of ICSI even higher, and there are some regions they use more than 90% of the started treatment in ART cycles with ICSI. And they are very interesting result in this study. They found that when the higher rate of ICSI use, they tend to have higher live birth rate. And this is not a strong evidence, but this is one of the reasons why they use more ICSI, more and more ICSI in their practice. And the same thing happened in Europe. The report of ASHRA in 2020 showed that ICSI was used in more than 70% of treated cycle, ART cycle in Europe, and it increased 6.5% compared to figure in 2014. The same thing happened in South America, Middle East, and Asia. Many centers, they do up to 100% ICSI on ART cycles. And recently, there are an article come out from data from the Latin America registry of ART. They also report the increasing of use in ICSI in ART practice. And based on this retrospective analysis, ICSI provide no improvement compared with IVF in non-male factor infertility. So why we don't have enough or good data to prove our expansion of ICSI in ART practice? But the rate of ICSI use is keep increasing rapidly recently. The reason not fully understood, but there are some possible explanations for this trend is because the technique is so is very easy now. The availability of the laboratory it's everywhere. There are some marketing or competition issues among the clinics, so that's why clinics tend to use more add-on techniques on the treatment. And because of so far we have no good definition for a threshold for male infertility, which can be used ICSI for treatment. And there are a big hope that ICSI might diminish the risk of total fertilization failure and the increase of number of embryo available with ICSI. So that's why we recently started a big RCT to again to verify the effectiveness of ICSI versus conventional IVF treatment for a couple with non-male factor infertility. This is our protocol published in early 2019. The study is to compare the effectiveness of ICSI compared with conventional IVF in non-male factor infertility infertile couples. Our major outcome is live birth after first embryo transfer. This is the first study ever to use live birth as a major outcome for the comparison. This is a multi-center randomized controlled trial. The sample size is more than 1,000, more than 500 patients recruited in each arm. And we started to recruit patients at the end of 2018. This is our study population, the inclusion criteria and exclusion criteria. We recruit patients who have not more than 2 previous IVF attempts, antagonist cycle, normal total sperm count regarding to WHO 2010 standards. We transfer 1 or 2 embryos per patient. And if the patient have history of poor fertilization in previous IVF cycle, we did not recruit that patient into the study. And all of the sperm using a fresh sperm. Actually, we presented the preliminary result of this study in ESRA this year. We found that in couple of non-male factor infertility, ICSI did not result in a higher ongoing pregnancy rate compared with conventional IVF treatment. We just finished the analysis very recently, and we submitted in the manuscript into a journal, and the final results show that there are no difference in fertilization rates for oocyte retrieval and total fertilization failure between IVF and ICSI for non-male factor infertility. Live birth after first transfer were the same between the two treatments, and but we found an absolute difference of 3.4% favor ICSI, even if not significantly different. And there was no difference in obstetric and perinatal complications between the two study groups. Interestingly, we found that the fertilization per oocyte inseminated was higher in the ICSI group, and the fertilization rate per oocyte retrieved also had a trend for higher in the ICSI group. The abnormal fertilization rate per oocyte inseminated and oocyte retrieved were both lower in the ICSI group. The differences were significantly. And very interesting, the rate of no embryo on day 3 for transfer is significantly lower in the ICSI group. And we think that there would be some subgroup of patients of non-male factor infertility can be benefited from ICSI treatment instead of conventional IVF, and we have to find out who are that kind of group of patients. Very recently, ASIM published a guideline show us what are the evidence we have nowadays to apply ICSI for non-male factor indication. And we also have a very interesting SWOT analysis to apply ICSI for all cases, published very recently. And based on that two publications, we go through the evidence for different indications for ICSI nowadays. For azoospermia with retrieved sperm, we have strong evidence for using ICSI. For severe male infertility, we have strong evidence. For moderate male infertility, we have evidence of increased fertilization rate and decreased fertilization failure with ICSI, but so far we have no defined threshold for male infertility that is suitable for ICSI. For unexplained infertility, we have some evidence to prove that ICSI will have to increase fertilization rate and decrease fertilization failure. In couple who have previous failure or low fertilization rate with IVF in previous cycle, ICSI could increase the fertilization rate and decrease fertilization failure. There are some weak evidence long time ago show that we can have better embryo quality with the ICSI compared with IVF, but it's not a very strong evidence. We also have some weak evidence to apply ICSI in the case that we have some issue with the zona pellucida. For ART with VGT, it depends on the genetic techniques. For VGT, there are indications for ICSI. And recently, there are some weak evidence that in case of with high sperm DNA fragmentation, ICSI could help. We have no evidence of low oocyte quality and no evidence of IVM oocyte or frozen oocyte. Yet these are some common indication for ICSI nowadays. We have evidence that ICSI will not work for women with low oocyte yield or women with high age. For non-male infertility with no history of fertilization issue, in general, ICSI is not effective regarding to live birth compared with conventional IVF treatment. But based on our recent data, we might have some subgroup of patients who should have some benefit with ICSI instead of IVF treatment. Regarding to the safety of ICSI compared with conventional IVF for couples with non-severe male infertility, there is a very recent article come out in Fertility Sterility. In general, there have been concerns about the potential risk of using ICSI in non-male factor infertility relating to the ICSI technique because it's bypass the natural selection of sperm in conventional IVF or in vivo. Yet, so far, we have no difference. We found no difference in obstetric and perinatal complication between ICSI and IVF with non-male factor identified. So the risks, if there is, might be relating to paternal underlying issues, not the ICSI technique itself. Anyway, we need more data at the medium or long term to verify the safety of ICSI in this particular group of patients. So, in conclusion, is ICSI nowadays still an add-on? We know that ICSI has been getting more popular worldwide, and this is now the main technique in ART practice. The indication for ICSI has been expanded rapidly during the past 20 years, and to some extent, it is now overused. And we need more data to verify different indications, especially for non-male indications of ICSI. For the safety of ICSI, this has become more reassured recently, but we still need more data, especially in medium term and long term, on the health of the babies. Of course, ICSI is more costly than IVF in most of the IVF programs, and we also have to be care of other issues like center experience. Some centers have very good experience with ICSI, and some centers do not. Many social issues patient require, or the competition of centers in a very competitive market in IVF, and also the financial issues in using IVF or ICSI. Anyway, it is the most popular technique used in ART, and we have more data to prove for different indication, and the safety issues is more reassured. ICSI can no more seems as an add-on treatment nowadays. I'm looking forward to for fruitful discussion on these issues with all of the respected colleges. This is my acknowledgement to my college and staff in our ICSI versus IVF project during the past 3 years. Thank you for your attention.